In this presentation, we're going to take a look at Bennett's fractures and Barton's fractures. A Bennett's fracture is a fracture at the base of the first metacarpal, which can lead to dislocation of the first carpometacarpal joint, and this joint is involved at the fracture site along with the trapezium. A Barton's fracture is a fracture of the distal radius and can lead to dislocation of the radiocarpal joint. The scaphoid and lunate bones of the carpal bones could also be affected as they articulate with the distal end of the radius. The bony anatomy of these two conditions includes just general wrist anatomy, such as the phalanges, metacarpals, carpal bones, scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, and hamate, as well as the ulna and radius. Bennett's fracture particularly looks at the first metacarpal and the trapezium, and Barton's fracture looks at particularly the distal radius. Signs and symptoms of Bennett's fracture include obvious visual deformity, pain over the base of the first metacarpal, pain and weakness in the motions of pinching and grasping, swelling and ecchymosis patterns over the first carpometacarpal joint, and the patient will be unable to perform activities of daily living such as tying their own shoes or using a key. Infections may be present as well as stiffness. In Barton's fracture, obvious visual deformity is a key sign, as well as pain over the distal radius, swelling and ecchymosis patterns over the distal radius and forearm, dorsal displacement, angulation, and comminution, which is where the bone splinters and breaks into many different little pieces, as well as radial shortening, stiffness, and you have to be aware of intra-articular versus extra-articular fractures. Predisposing factors of these two conditions include increased age, which can lead to osteoporosis where the bones become brittle, gender, women that are particularly 40 years old or higher are more susceptible to both of these conditions, and sport participation such as those that play football and wrestling. Mechanism of injury for Barton's fractures include fooshing. They occur in younger individuals with high energy traumas, such as a motor vehicle accident, a fall from a significant height, or athletic injuries, as well as in older individuals, which typically happens in more low energy or moderate trauma situations, such as falling from just a standing height. Bennett's fractures occur through an axial load on a partially flexed metacarpal, as well as fooshing and athletic injuries. Pathologies for both of these conditions include obvious visual deformity, intense pain, edema, and ecchymosis. It's just what or where these are surrounding, such as for Bennett's fractures, it would be surrounding the base of the first, and Barton's would be surrounding the distal radius. Special tests include just general fracture sign tests such as the Tapper percussion test, the bony stress test, and the compression test. Treatment-wise, you want to splint, cast, or spica the area that is injured, cryotherapy to reduce or limit the swelling, and surgery is an option, such as open reduction and internal fixation with screws, and this is for more unstable fractures and inter-articular displacement that is greater than 1 millimeter. Mobilization, like I said before, splint, spica, or cast, and any of these are for typically 3 to 4 weeks. Referral and management includes if these are all positive, such as the special tests, the pain, edema, ecchymosis patterns, obvious visual deformity, then a splint or a spica should first be applied. Use ice to limit any further swelling. Refer to an orthopedic doctor, or in severe cases, refer immediately to an emergency department at a local hospital, such as an emergency room or an orthopedic surgeon. And you manage both of these fractures with immobilization, non-steroidal anti-inflammatory drugs, and rest. Prevention, you can tape around the thumb and the wrist, especially in sports where the hands are used frequently, like linemen in football. You want to strengthen the muscles and the tendons of those muscles that run through the distal forearm and into the hand. Consume adequate amounts of calcium and vitamin D to strengthen your bones. Exercise for 60 minutes a day, several minutes a week, and this also depends on population. And with those less active, you might have to start at smaller workloads, such as decreasing the time and days of the week. And then make sure that medication is being used properly, if medication is used at all in this situation. Differential diagnosis for Bennett's fractures includes Rolanda fracture, gamekeeper's thumb, and they are particularly found through inspection and palpation. In a Barton's fracture, radiographs are recommended to be taken, and differentially diagnosing this includes triangular fibrocartilage complex tear, Galeazia fracture, scaphoid fracture, radiocarpal ligament tear, distal radius malunion, compartment syndrome, complex regional pain syndrome, Dupuytren's disease, and carpal tunnel syndrome. Here's my PCOT. From an analysis perspective, the population included 19 patients with volar Barton's fracture. However, only 16 cases were available for study. The intervention was open reduction and internal fixation surgery. There was no comparison. And the outcome was where the fractures healed after 7 to 10 weeks. And in a functional criteria, 9 cases were excellent, 5 were good, and 2 were fair. Radiocarpal osteoarthritis developed secondary to trauma in 2 of the cases. There's a mean time frame of 32.4 months with these conditions, and the range included anywhere from 12 months to 65 months. And here's my works cited.